Lupe graduated from Eastern Washington University, began working at Kootenai Health in 2008. Lupe is passionate, I can claim that, about swallowing disorders and cancer rehabilitation. She enjoys working with oncology, GI, ENT, and dietitians. She is excited to share her knowledge about rehabilitation services. I encourage you, after hearing her, or even during her, I really believe she's going to create some questions, and I want you to ask them, and she wants to get them. So, at this time, I will collect all my junk here, and Lupe, it's yours, hon.
So, I'm not the techiest either. And am I just going to click through?
Yeah, just the arrow button should move you.
Okay.
I got you water.
Oh, thank you. That's super
Okay.
sweet. So my biggest stance is prehabilitation. A lot of you might have heard of rehabilitation, which is repairing and regaining function that you may have lost because of a surgery or a treatment. But you are going to be better prepared for your cancer treatment if you go into prehabilitation. Strengthen as much as you can before you start getting cancer treatments. A lot of my patients, when they come in, they're probably going to lose weight. So I ask them to gain a little bit more cushion. And so that is my insurance that hopefully they won't lose too much weight and we can get them through the cancer treatment without them needing a feeding tube or other means of nutrition, because your mortality rate goes up significantly if you are dehydrated or malnourished. And so if the cancer doesn't kill you, the cancer treatment might, if you are not set up to be successful during your treatment. A lot of patients, when they come in, usually the ear, nose, and throat doctor or their oncologist might say, I need you to see a speech language pathologist. Then all of my patients say, I don't need to go in, my speech is just fine. But what they don't understand, because they don't know, is that a speech language pathologist can work on everything from the waist up. The waist down, we leave it to the PTs. They can have that. But we can work on everything from the waist up. That includes breathing, swallowing. It includes speaking, thinking, cognition, all of the things that you need to do to drive, to work, to communicate with your loved ones, to advocate, to talk over the phone, to order fast food through the drive-thru. All of those things a speech language pathologist can help you with. So a lot of my sessions, I ask the oncologist to send me these patients before they even start treatment so that I can set them up on what to expect, what the timeline for their treatment is going to look like, when the worst part of it's going to be. And then I try to focus on preventing things like oral sores, preventing things like the dehydration, preventing or reducing the skin injury that might occur from the radiation burns. What many people, including physicians, don't realize is that breathing and swallowing are using the same musculature in a very coordinated fashion. If you cannot breathe, you are not going to be able to eat. Breathing comes first and then swallowing. The way the brain works is that actually your child, when they're growing and developing, you're not even supposed to start feeding them solid foods until they can sit up, because the first priority of the brain in development is to protect the head. So if there's a risk of falling and injuring the head, you are not ready to eat. And so a lot of these things that happen naturally in development, we need to start working on coordinating breathing and swallowing so that you don't lose weight. And so if you do lose weight, we can get you back to a healthy weight. If you do happen to need a feeding tube, we can have an exit strategy for that feeding tube. Because if you don't have an exit strategy and you end up having a feeding tube, Many people think, well, we can just pull it out. After I'm done with cancer treatment, we'll just get rid of the feeding tube. But if you stop eating and if you stop drinking, your muscles will shrink away within 3 days, a 3-day weekend. And then I'm going to have a patient that I'm going to be working with for maybe 2 years to get rid of that tube. So I don't want that. My goal is, let's set you up to be successful so that your cancer treatment doesn't ruin the rest of your life, because you still have a ton of time and all these beautiful opportunities. Eating is so important socially. We met up for coffee this morning. We eat when we're sad, we eat when we're excited, we eat to celebrate, we eat while we're watching football, we eat while we're bored. So imagine if somebody takes away the ability to eat. And those are the kind of patients that I work with. My youngest patient has been age 3, and he was a little bit less compliant than some of my adult patients, but a lot of it is attitude. And what I try to do is I try to give people hope when they come into rehabilitation therapy, and I try to guide them. Maybe I'm not the person that's going to be able to help them, but I can definitely send them to a physical therapist that does lymphedema that might be able to help them, or an occupational therapist. Many people, when they come in, they say, well, why do I have to see an occupational therapist? I'm retired. I have no job. But an occupational therapist does an amazing job at helping people become as independent as possible through getting dressed, through bathing, cooking, a lot of cognitive stuff. We have a driver's evaluation that can be done. And if accommodations need to be made, occupational therapists are amazing problem solvers at helping you accomplish the things that you need to do to stay as independent as possible. I love all of my patients, but I don't want to see them forever. So typically, when we do a rehab plan, it's very individualized. It can be 12 weeks, it can be 14 weeks, or it can be shorter. With the way insurance works, sometimes it's easier to ask for more and then taper it back if we don't need it, or ask for more, be told no, and then meeting somewhere in the middle. So that's what speech language pathology does. So cancer and the cancer treatment, they usually result in changes to your body, your psyche, your cognition. Jim was talking about chemo brain, and that's a real thing. A lot of my patients think, well, this is just part of getting older. No, it's not a part of getting older. It's a side effect of your medication. And so why not go through and tweak out how much of this is likely to continue to get worse? What if we could prevent some of that chemo brain? Or what if we can make it better so that you can stay as independent for as long as possible? And a lot of these cancer treatments, surgery, drugs, they can affect your hormone levels, and it can lead to PTSD. There's a lot of things that can have long-term outcomes that we can treat. So it's almost like, why wouldn't you want to get treatment? The cancer rehabilitation can address some of these changes. These changes don't always take place immediately. Sometimes it can take 3 months. I've seen patients 15 years later after their treatment's already done, and now they're really suffering. So that's why I'm a very big advocate of starting early. You might not know why you're seeing a physical therapist or an occupational therapist, but it's always okay to ask. And you can ask your therapist, how much experience do you have working with my type of cancer? And what are some of the things that you see with patients who suffer with my type of cancer or my cancer treatments? That is okay, because you want to know what to expect. You want to know what to look for so you can create a plan. What are you going to do after cancer? Many of my patients, I see them before they start cancer treatment. I see them every 2 weeks. And then once they're done with cancer treatment, They want to be done with all of their appointments. They want nothing to do with cancer. They want to put it behind them. And that's a nice dream, but you're really setting yourself up to have more appointments in the future after you've already had some potentially permanent changes to your body. So that's all the more reason to ask what to expect once you're done with your cancer treatment. And many people don't realize that you can come up with a cancer summary of your treatments. You can ask your cancer team, what drugs did I use? What was the stage of my cancer? Where was the location of my cancer? And what parts of my body were exposed to radiation? They can even create a radiation map where it has your body and it shows what parts were exposed to radiation. The reason that's so important is because you want to know, were your carotid arteries exposed to radiation? Was your heart exposed to radiation? Were parts of your lung exposed to radiation? So you need to be aware and arm yourself with some of these things that are available to you. I had a patient and I said, you need to look this up on your MyChart. And he said, I don't want a MyChart because I don't want my information out there. So my response was, your information is already out there. The only person you're denying access to is yourself. So you need to get access to that MyChart so that you can arm yourself with these tools so you can ask better. Many of my patients, most of them are head and neck cancer patients, they don't realize, hey, you now have an increased risk of having a stroke. You should probably develop a good relationship with a cardiologist so you can get ultrasounds for your carotid arteries. They don't realize, hey, now your thyroid has been radiated, so guess what? You should probably get your thyroid function checked because your thyroid can, if it dysfunctions or malfunctions, it can lead to all sorts of other problems. Hey, you had lung cancer, your lungs were exposed to radiation, guess what's next to your lungs? Your esophagus or your heart might have been exposed to radiation. Some of the chemotherapy drugs that you're on have long-term effects that can impact your hearing, causing permanent tinnitus or tinnitus. They can cause permanent hearing loss. So your oncologist did an amazing job of saving your life. Now I have to arm you with the tools to continue to improve the quality of life that you have. And you are more than welcome to ask any questions because I feel like I'm talking too much. So staying active as much as possible, those are our goals from rehab. Any physical therapist, occupational therapist, speech therapist, we want you to be as active in your work life, in your family, in your communities. We want to reduce some of the potential side effects and symptoms of your cancer treatments, including any surgical changes. Surgery can also impact how your lymphatic system drains, so it can lead to lymphedema and swelling. Does anybody know what lymphedema is? Yes. So huge. It's very devastating. Lymphedema can also start to compress some of the nerves. You can develop neuropathies from some of these issues. So our goal is always independence, 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 and quality of life. So some of the kinds of problems that I'm used to dealing with that would require like a referral to a rehabilitation center is lymphedema, reduced range of motion. If you have any kind of scarring and all of a sudden you went from being able to lift your arm this much, well, with time, you're only going to be able to lift up your arm this much. And then we're not even talking strength, we're talking about range of motion. So I had a gentleman, he wanted to shovel gravel. Well, this is as much gravel as he can shovel. So if you can get to a physical therapist, we can improve your range of motion for your limbs, your extremities, even your throat. You can start to lose range of motion with your tongue, with your throat muscles, and that's going to impact your ability to speak, to sing in church choir, to breathe, to swallow. So all of those things we can work on, but you have to get to rehab first. Some of the emotional changes. So when you are going through your cancer treatment, I was telling Jim, my patients are very scared, they're very angry, and now once they're done, they ring that gong, they've been declared cancer-free, and you're supposed to quit being scared and quit being angry. How likely is that to happen? It's not going to happen. You can't just turn something that's so embedded in your brain to be scared, because fear and anxiety is actually beneficial to your survival. Fear and anxiety is what keeps you alive as long as it is functional. It makes sense to be scared of cancer because it can kill you. Well, what are you going to do when fear and anxiety is no longer functional and now it's actually impeding your function? It's causing you stress. Stress leads to more cortisol levels, autoimmune diseases, and cancer. So I really suggest a lot of my patients seek out either somebody they can talk to at the church, somebody that's trained, like EMDR training, which it's a PTSD type treatment that's used with soldiers after war. It's amazing. It's an amazing process. So I always advocate EMDR, which is eye movement reprocessing desensitization, something EMDR, desensitization reprocessing. And the long-term effects of chemo and radiation. Radiation is the gift that keeps on giving. Radiation will continue to work. I have patients that come and say, I'm all done with cancer treatment. We finished my last radiation. And I said, that's great. You still have radiation working in your body because that's what it's designed to do. So radiation doesn't just attack your cancer cells, it attacks healthy cells. And so radiation can shrink healthy tissue. So that's what happens with radiation. You continue to get weakness. I have patients who have been radiated on one side of their neck 15 years ago. They can't lift up their head because of long-term effects of radiation. There's some new research that's going on about reducing the risk of radiation-induced fibrosis through hyperbaric chamber therapy. And a lot of my patients, I am trying to get them into these hyperbaric chamber therapy sessions. And I can't refer. All I can do is educate the patient, say, hey, have you thought about looking into this? Here's a pamphlet. And then the patient really needs to take that on themselves and find out who can help them get that treatment. I had a patient come by and she had her head and neck radiation done many, many years ago, over a decade ago. And she said, well, Lupe, my friend told me that it's too late. It's too late for me. I can't get any hyperbaric chamber therapy. That is not true. It can still benefit and it can still slow down the process of that fibrosis, which is permanent scarring. Because once you have that scar tissue, it's very difficult to work with. Scar tissue, imagine that my arm is a muscle fiber. It's innervated by a nerve. This muscle fiber can only contract in one direction when it is linear, when it only contracts in one direction and it works. Then you have radiated tissue, which turns into a knotty ball of scars. No matter what nerve is telling it to move, it can't move the same way. It's scarred. So that is radiation-induced fibrosis. It's scarring that impacts the muscle's natural ability to move the way it's supposed to move. Feel free to ask questions.
I have a shameless plug.
Yes.
So the company that Taryn and I'm also a physical therapist. The company that we work for, Northside Physical Therapy, has actually a couple of hyperbaric chambers in the area. So
Taryn told me, and I'm very jealous.
that's something I would definitely clear with your doctor first.
Yes, you need an order, and it needs to be cleared by insurance.
There are several, and even other companies have them in town too. So there's more and more popping up.
Mm-hmm. Yeah, and it's not too late. And you know what? Even if it was too late, and I have no way of knowing what that means, I would never take someone's hope away. I'm not the doctor that's going to be doing that kind of treatment. I would refer and say, go get a consult. If it's not the opinion you like, go get a second opinion. It's not going to hurt anything. Because really, you're the one that stands to benefit from a potential treatment. Right? Okay, so who will be there to support me? In a perfect world, your spouse will be there to support you, but we all know that relationships are not perfect, and it's not a perfect world. So sometimes the support system, I always ask, who's your support system? And sometimes it's my niece, my nephew, my family, my wife, my hot new girlfriend. I don't know. It really, to me, all that matters is you have somebody that can go with you to these appointments. When I went to my husband's oncology appointment, he was so scared. I don't even think he heard half of what the oncologist was saying. And then he left with a huge list of other appointments and tests that he had to make. So here I am, writing everything down, like the spouses that I work with, writing everything down, trying to get some sense of control. And then even though I knew what I was doing and I knew what I was talking about, he still was like, I don't quite think that's what the oncologist said. And I said, yes, the oncologist said you needed a mammogram. He goes, I think there was like a handheld mammogram I was supposed to take. And I was like, oh my gosh, there's no such thing as far as I'm aware of. A handheld mammogram does not exist. But the point is, it's a ton of information, and it's very important information. And it will help guide your treatment plan, and it will help guide how you go through with your treatment plan. I ask my patients, if you don't understand why I'm asking you to do something, ask me, because I will explain it in a different way, but I need you to understand why I'm asking you to do these things, because it's very important. Otherwise, they're going to leave and they're going to say, well, now I have these sores in my mouth and now I can't eat. Now I'm in pain. My whole mouth is one giant sore. And I'm going to say, well, did you use the coconut oil? Did you use the baking soda saline solution? Did you try the Xylomelt? Well, no, I didn't realize that that's what they were for. And so it's a huge miscommunication that can be avoided. Bring somebody with you, because you also need somebody to help you advocate. When my husband went in, he goes, well, no, I don't have a history of cancer. Yeah, no, just remove this cancer and then we'll be done. And I was right there saying, wait. He found a lump in his left breast, and he has a family history of every grandparent has had cancer, every parent has had cancer, every aunt and uncle has had cancer. So that triggered a different treatment plan, right? So now the oncologist was thinking, okay, well, now we need genetic testing. Now we need a mammogram. Now we need an ultrasound. And my husband was trying to kick me under the table. But this is why you need a friend. You need a support system. In a perfect world, it's your spouse. Your spouse might be more scared than you. The trauma that your spouse goes through, if you have a spouse going through this, it's different. It's still trauma, and it's still scary, and people deal with their trauma differently. So sometimes the spouse is there, sometimes the spouse isn't. That's okay. But really, the patients that do well have a sense of community. They might have a church group, they have a family, they have neighbors, and later they go and receive counseling. You can talk to your primary care physician. That's what the PCP stands for. You can talk to your physical therapist, your occupational therapist, your speech therapist. And you can even ask, have you seen this before? Because I don't know why, but there's a huge sense of relief when you know, oh, okay, it's not just me. I'm not the only one. This happens. This is a thing. And you know what you're doing, and you know how to treat this, so we can get through it together. A lot of the specialists that I work with are oncology, dermatology, ear, nose, and throat, cardiology, GI. My friend works at the GI. She calls them the butts and guts doctors. I think that's hilarious. It's very appropriate. When my husband finished his cancer treatment, I said, hey, you have to get a colonoscopy. And he worked so hard to get this colonoscopy. And I think he was like, well, if it's not meant to be, it's not meant to be. But he did it. And that's they did remove a polyp. And they said, yes, it was precancerous. We're so glad we got it in time. And that was the call he was waiting for. He said, well, no news is good news. And I was like, no, you can't do that. You can't just say that. Your doctor is not sitting in front of your lab work waiting for it to come in. Your doctor is busy seeing a ton of other people. You are that one patient whose labs mean the most too. So you need to make sure that you are asking, did that lab work come in? What did you find? And if you don't understand what the lab work means, it is 100% okay to ask, what does that mean? What should I do? What do I need to do with this information? My patients even ask me, what would you do if you were in my shoes? Everybody's different, but my job isn't to tell people what to do. My job is to educate them. And I think you would agree as well. Your job is to educate people so they make the best choice for their treatment plan. Because you're the one going through the cancer treatment. You're the one going through the rest of this new body. This is the new body that you have after surviving cancer. This is the new body that you have because you've had cancer. So this is not the same body that you started off with prior to your cancer treatments. This isn't even the same mind you started off with prior to your cancer treatments. You are forever changed because this has happened. And so you need to change moving forward. I was telling Jim, I said, it's really important for these patients, once they go through the cancer treatment, they have to grieve what they had. You grieve this loss of, not loss of innocence, but you had this idea prior to cancer. Cancer happened to other people. And then cancer happens to you. And it has forever changed your life. Your goals moving forward might be different. Your aspirations moving forward might be different. You now have these scars, maybe from surgery, maybe from biopsies. And now you have these long-term effects of these medications and these drugs that you had to take to survive cancer. You probably wouldn't change anything to get to where you are because you survived and it led to your survival, but you still have to educate yourself as to, okay, this is my new body. Unless you have a spare one lying in the backyard, this is it, right? You might, I don't know. A lot of the physical symptoms that we deal with in rehab are pain, swelling, weakness, loss of strength, range of motion, flexibility issues, endurance or fatigue. Some of those chemo drugs, they can lead to that chronic fatigue syndrome, and we can work with fatigue and endurance. Mostly PT, not so much me, but I always refer to PT. Radiation fibrosis, surgical scarring, and PTs are amazing. They have these really great tricks on what they can do to reduce how limiting that scar is, to make it more pliable, to make it so that it doesn't really reduce your range of motion. And so when I see significant scarring, usually it's on the neck or scarring on the back or arms and legs, then I will refer to a physical therapist because they're just amazing at that part of it. The lymphedema. My thing with lymphedema is swelling of tissue because it cannot move lymphatic fluid the way it's supposed to, the way it's meant to. It is not managed just with massage. A lot of people think, well, I'll just go see a physical therapist and they will massage and I will be all done. That's not how lymphedema works. And it's a very specific type of manual lymphatic drainage. If you rub too hard, you can actually start to cause damage. So with lymphedema, I always say, please make sure that your lymphedema specialist has a board certification and has the hours and they understand that you have gone through cancer treatment. Because not all PTs are the same, right? Balance issues and vestibular issues. Some of the chemo drugs are known to cause balance issues and vestibular system issues. I'm thinking of cisplatin. Cisplatin is very common. It's an amazing drug used to treat head and neck cancers. And it leaves the body very quickly, but it damages the inner ear. So it leads to tinnitus and leads to hearing loss, and it leads to balance issues. Remember at the beginning we were talking about how your head is designed to be protected. If you are at risk of falling, you're not going to eat. So if a patient has poor posture, I struggle to get them to eat. So if your vestibular system is off kilter and you don't see a physical therapist, there's a real risk of falling and injuring your head or breaking a hip. And it's sad because it's very, very preventable. Neuropathy, a lot of the neuropathies that happen can be from radiation and nerve damage that's done during radiation. Sexual dysfunction, problems with swallowing, problems with chewing food, problems with breathing. A lot of our head and neck cancer patients might lose all of their teeth. And then you have your jaw. Let's pretend that this is the TMJ joint. Your teeth are supposed to fill in this space. And so when you chew, there's teeth here to help you chew. Then you lose all of your teeth, and dentures are not the same as regular teeth. Dentures are a plate that now make it so that you can't sense the temperature of food. You're more likely to get burns. It does not have the same ability to chew. Your jaw, when you're chewing with natural teeth, you can chew with 150 pounds per square inch. When you're chewing with dentures, 20 to 30 pounds per square inch. It's terrible. And so it's not the same. And then people try to just gum their food. Well, now you have to damage your joint because you're trying to get gum to work to chew your food. So I work with patients on changing their diet. I don't take away foods from people because it doesn't work. Most of the people around here are steak and potatoes kind of people. So I'm not going to take that away, but I do change their diet so that they can eat, not lose weight, and stay as healthy and as happy as possible. If a patient comes in and they say, my goal is to eat cake, okay, what kind of cake do you like? And we'll eat cake. But most of my patients are steak and potatoes kind of people. Anytime I try to say, hey, what about some broccoli? No. And I think one patient was like, well, I asked him, do you eat any vegetables? He goes, corn's a vegetable. I was like, no, but okay. So I think my suggestion for him was shepherd's pie from Costco because it's calorically dense. It's got a ton of calories, a ton of half and half.
And it's delicious.
Well, there you go.
It really is.
So I work with people to get them to eat what they want to eat. I don't take food away. I don't thicken food or liquids. There's a myth, I hope it's a myth, that a speech therapist will always thicken your liquids and give you that thick stuff. I try not to do that. 1, it dehydrates the patient. 2, it might increase their blood sugars if they're diabetic. 3, they're not going to do it. So it's a waste of time. So I like to have them drink things that are maybe naturally a little bit thicker, like protein shakes or Kerns or Clamatos, something that has just a little bit of thickness. And I will always say you need to drink more water. That's the first thing I tell people. You need to drink more water. Your brain is floating in a saline solution. It fires electrical signals. It needs a conductor, so you need to drink more water. Well, I drink 12 cups of coffee, and there's water in my coffee. I'm like, no, that is not the same. Your brain is not floating in coffee. It is floating in a saline solution. So the most important thing that I ask is please drink more water. That's a cure to a lot of things. Just drink more water. Okay, I'm trying to figure out how to, okay. So mobility symptoms, difficulty getting up off the floor, difficulty getting out of your chair, difficulty climbing stairs. If you don't have a rancher, how many steps does it take to get into your house? Difficulty walking, difficulty getting dressed, difficulty showering. That's how a physical therapist and an occupational therapist, they're going to ask about these things. When a speech therapist that doesn't work with these things, I am watching. So as soon as I go out to pick you from the waiting room, I'm watching to see how you're getting up out of that chair. And if you wobble a little bit, I might ask you to see a physical therapist because I don't want to take that risk of you falling. One, I don't want you to get hurt. And two, it makes a lot of paperwork. So I'm kind of joking. Cognitive symptoms, difficulty multitasking, mental fogginess, difficulty thinking clearly, difficulty with memory, difficulty with word finding, being able to participate in a conversation, coming up with the words that you need when you need them. Those are all things that maybe we could work on if you saw a speech language pathologist. And many of our patients will say, well, that's just kind of part of getting older. No, I know plenty of people that are older and they're very, very sharp. So if I have the same standard for them, I want that same standard for my patients. So how to advocate for yourself. Learn about your type of cancer. Oh, go ahead.
How about the stress effect on your thinking?
Mm-hmm.
I mean, I felt like I had chemo brain without chemo.
Yeah.
I felt like 3/4 of my brain wasn't working, and I only had like the quarter of it to do things with.
Yeah.
Especially like deductive reasoning,
Mm-hmm.
which I think has gotten better, as time has gone on, but I don't have a good way to measure that.
Well, and stress causes or can cause, I don't like using the D word, dementia, because I think it's just a description. People associate dementia with Alzheimer's dementia. But really, when you're thinking about word finding and memory and remembering and multitasking, stress causes that to be more difficult. Fear causes that to be more difficult. If you're in fight or flight mode, like you are during cancer treatment, that's not a priority. Word finding is not a priority. You're stressed. And so stress and depression, all of those things can cause issues with mental faculties. So can dehydration. So can UTIs. Dealing with an infection can cause you to have difficulty with memory. I just overcame some kind of lung infection. I would not have done well on a cognitive test. I didn't feel good. And so if you're scared or if you're in pain, you're going to struggle a little bit with cognition. I like what you said about I have no way of telling. So if that's a concern, you can always go in to see a speech language pathologist. We'll do a baseline evaluation, and then it's on record. You have an assessment that says, hey, back in October of 2022, I could do this. Now I think something's changed. We'll have something that's closer to a measurement tool so we can notice if there is a change. Yeah? So learning about your type of cancer and its treatment. What do other people experience after cancer treatment? I'm thinking more specifically for like head and neck cancer. When my patients leave my session, congratulations, you graduated from therapy. I give them an article of what to expect. These are all the things that are possible because of your exposure to radiation in that specific area, because of surgery. Some of the most common symptoms are chronic dry mouth, and I think Jim and I talked about that. Chronic dry mouth, thyroid issues, the carotid arteries, all of these other things. So figure out what your cancer treatment was and how that's going to progress. Develop a relationship with your quarterback. The reason I use a quarterback is because a lot of my patients, they may or may not have a primary care physician. People retire, people move, and so now they're seeing all these different specialists. Well, the right hand doesn't know what the left hand's doing, right? So you need one person that you can talk to. Usually, I feel like the primary care doctor is really good to send off your referrals. I really love internal medicine because you don't need your oncologist anymore. You're already cancer-free. You've already been cleared. You don't need to go see another oncologist, but you want a specialist who knows you've been through cancer treatment. Now what do we need to watch out for? And so that's the quarterback. Usually GI is not your quarterback. GI is like a linebacker or a receiver. I'm not great with football, but you want someone that can track all of this information. Be open and honest about your needs and your goals. I feel like sometimes when things are related to bowel and bladder or sexual dysfunction or hormone changes, I feel like people aren't as honest or as open with their doctors as they should be. I know that my husband, I asked him, I said, well, did you tell your oncologist that you missed that dermatology appointment? He goes, well, no, I just don't think it's that important. And I said, well, I think it's kind of a big deal. Why didn't you tell her? He goes, because she would have gotten mad at me. And I said, well, that just shows he knew it was a big deal, but he chose not to do it. So that's the thing. You need to be comfortable with being uncomfortable. You already went through the hardest part of the cancer treatment itself. So now you need to be open and honest about, hey, I've noticed I don't have as much pep, or I noticed some of these, like the fatigue or the sexual dysfunction or the urination issues, chronic urination or bowel and bladder, incontinence. Those things need to be addressed so that you can have the happiest life possible, the best quality of life. I know that my father-in-law was telling me he ended up in an institution because he didn't realize all of his hormones were off after going through prostate cancer and getting radiation seeds implanted. It just did so much and led to some depression issues and hormonal imbalances. And he really did need the help, but he didn't realize that they all kind of tied together. And so just be open and honest with your physician. I don't feel like physicians are usually pretty judgy. They want to be helpful. People that go into this field, it's because they want to help others. And so you really need to let them know what's going on. Maintain your annual appointments and follow up with imaging and testing as necessary. Don't skip it. Just go. Get it done. Get it over with. How are we doing with time?
Oh, you're good on time.
Okay.
I have some questions.
Yes, sir.
The lack of water, I
Mhm.
can understand for the chemo break thing.
Mhm.
We discussed the dry mouth issue. I still deal with that sometimes. Is that caused mainly by lack of water, or is there other things that cause that dry mouth after chemo?
There are many, many medications that can have a side effect of dry mouth. There are many medications that on their own won't give you the side effect, but then once you take multiple of them, you will have dry mouth. A thyroid issue could give you dry mouth symptoms. Just low-level hydration, like you might be hydrated just enough not to die, and then you're going to get dry mouth. But usually for my patients, it's radiation-induced swelling and radiation trauma to the mucus, so the membranes that create that mucus, or the salivary glands. So they've been exposed to radiation. These salivary glands have been radiated. Now they have really awful dry mouth. But for other patients that haven't gone through all of the same cancer treatment, it's usually medications. And there are these products you can purchase. They're called Xylamelts. I really love them. I don't encourage getting the knockoff brand because they don't work the same way. So Xylamelts are these little tablets that have an adhesive side on one and then a lubricating side on the other. You can actually sleep with them in. They will not fall off. And you can eat and chew and swallow liquids, and they will stay in place. I recommend them to anybody who has diabetes, because diabetes leads to a lot of dry mouth symptoms. So do the medications. So you just buy them. They're called Xylamelts, XYLI melts. You can get them at Walgreens, at Rite Aid, and they just adhere. And I had a patient who said, well, I only use it when I have dry mouth, and they don't work. Well, it's kind of like chapstick. Are you just going to put on your chapstick when your lips are already burnt and crispy? Or could you put them on before your lips get chapped? And so I really think the Xylamelts are amazing. It's an amazing product, and I've gotten them for my family. I also work with like things that are going to create that lubrication, like coconut oil, swish and spit into the garbage, not to the sink. It'll clog up your drain. And I'm not a plumber. So the pineapple juice, papaya juice, a lot of those things have that enzyme that helps break down some of that protein. So it can also help with lubricating the mouth and getting that nice moisture. Some of my patients really love aloe water. So I always think, oh, I saw that face. If you can get over the pulpiness, or you can get one that doesn't have any pulp in it. And I really like the ones that have a little bit of sugar. I'm not a big fan of sugar. However, it's still, if it tastes better and it increases compliance, then I'm okay with it. But the aloe gel is similar to how you would put aloe on an external burn. You can also drink the aloe water. And it is called aloe juice or aloe gel, aloe water. And that helps too. Mm-hmm. Do you have any other questions?
No.
Okay.
You know, I have ringing ears. I guarantee it. Part of it is chemo. There's collateral damage of that. Anytime you look on the Facebook or anywhere, 5 million people have an answer for your ringing ears. I've seen weird pictures with Coke bottles stuck in there and wax balls and apples hanging over your head, and it's going to take it all. What is the real answer for ringing ears?
So I don't have the real answer for ringing ears. Some of my patients that do end up with tinnitus, I ask them to speak with their audiologist. I know some of my patients have had success with noise cancellation. Like some of the AirPods have noise cancellation, and some of them like it.
So do hearing aids. The new ones have that.
Yeah. And some of them have been able to sleep through it.
Built in. You have an app on your phone. And you use it.
Yeah. So some of the noise cancellation apps work really well for some of these patients. It really just depends on the severity of the patient. But yeah.
I have to address that. I've just put it off for so long, probably which I have created more of a problem than it should have been.
But every day is a new day. And we are all an evolution of ourselves. So you wake up in the morning and it's a new opportunity, right?
It's just something I have to address. One other quick question, I'll open it to somebody else. My wife shared today that she read somewhere or heard, where did you hear about that melatonin thing?
Oh, from a gal from Longevity.
A fellow warrior from Longevity, which is a huge lung cancer research in Bethesda, says that she is on melatonin because it's good for her lungs. I thought that was like a sleep aid or a relaxant of some type. Have you ever heard that, or do you use that? Or?
So I do use melatonin, and I always ask, what is it called, CYA? I always tell people, talk to your doctor first. However, melatonin is something that occurs naturally in your body to help manage sleep cycles, to help you reduce that overexcitability that we have that can lead to cancer, that can lead to other things, autoimmune issues. And so if melatonin works for you, then do it. It's available over the counter, and just as long as you're talking to your doctor, there's a lot of really good benefits. So if ever you have questions about melatonin, there's a lot of supplements out there. Melatonin, soursop, or amla, or all these other supplements that are available. You need to do your research because some of them are very helpful. I like the melatonin. It helps me sleep better. And so if it helps me sleep better and it helps my circadian rhythm, sleep is the only time your brain can actually heal and repair the body. So if it improves sleep, I would do it. But definitely talk to your doctor.
She doesn't use it for sleep. She uses it for her lung health.
And I would check the dosage, right? Yeah. And so if it helps with lung health.
We had just never heard that.
No,
Jim's
I
stage 4 lung cancer before, so
Never.
that was interesting.
That's why.
Yeah. No, I think, yeah. No, Google doctor.
No,
Google doctor.
Google doctor does that.
But there are a lot of supplements that do help, and they would be beneficial.
No doctor do.
Maybe not. I don't know how it impacts directly, but I love the melatonin I use, so it's probably not the same dosage that they would recommend for lung health.
It was just something that came out today.
Mm-hmm. And I always tell people, I'm not a doctor. I'm not a doctor. My role isn't to tell you what to do. My role is to educate you, and then you come back and tell me what you did, what worked, what didn't work, how can we continue to improve the symptoms that you have. And I am not a doctor. I have a lot of degrees, but not MD.
How do you handle negative attitude? What are some things that you can, somebody that's given up, quit, I have cancer, I'm going to die, I'm going to go pick the color of my coffin. What do you do with that?
When a patient usually comes in, they're not usually at their best. I'm not seeing them during their best moment. They're usually very angry or sad, and they'll say things to me because I happen to be the person right in front of them. That's not personal. I can't take that personally. Usually I say, okay, what are your goals? What are your goals? How can I help you meet your goals? Most people, when they come to see me, they might have a bad attitude, but a part of them is still wanting to beat cancer because they're participating in the treatment. They're showing up. So the fact that you showed up, the fact that you're going to your cancer treatment shows that subconsciously maybe you are still wanting to fight and you are not willing to give up. And so when I have these patients and they have a bad attitude, I just take it. I take it because it's not mine, and I'm not going to give it back to that patient. I'll say, okay, you need to put this on the calendar. You need to get through it because it's going to keep going with or without you. Time's going to keep going. It's not stopping for anybody. Your cancer's not going to go away on its own, not with that attitude. And so make the appointments, go to your appointments, show up. If half of the battle is just showing up to your appointments, that's amazing. But also know, like, make a goal. I ask all of my patients, make a goal for when you're done with your cancer treatment. Make a goal so you have something to look forward to. Maybe it's just going out to celebrate with dinner. Maybe it's going for a hike with your grandchild. But make a goal and set it up because that date's going to come no matter what. That's it. Thank you.